Okay. Okay. And okay. Tell me if that stops happening at any point. So, as I said, I think the traditional way to teach this is perhaps to start with health conditions or menstrual disorders that are aligned with menstrual problems. But as a GP or as somebody seeing people when they're first coming, that's not what I see. I don't see a diagnosis. I see the people who have come to tell me about what they're noticing in their body and the symptoms they're having and the trouble that they're having with them. So in pulling this together, I'm going to start with that perspective because that is how we see people, and then we start thinking about what we might do and what differentials we might consider and when we might consider them and how we might kind of move through offering them care. But I then will touch on some of the conditions that are associated commonly with menstrual symptoms or menstrual difficulties or menstrual clinical presentations. So I'm just going to touch at the end in the kind of more conventional way of teaching, perhaps of thinking a bit about endometriosis, adenomyosis, and polycystic ovarian syndrome, and possibly a bit about PMS, PMDD. So this is very pragmatic. It's not exhausted. I chose the symptoms that I most commonly see in practice. There are many unknowns and many other things that can come. But what I'm going to start with is thinking about the things that people come and tell me about, which is painful periods, heavy periods, and irregular periods. I've pulled them apart a little bit, but that's obviously a bit of an artificial distinction because they do, can, and often overlap. So we know that heavy periods tend to be more painful, probably through the mechanism of kind of classing clots or for just the mechanisms of bleeding. But also the experience of periods is more uncomfortable and more difficult when they're very heavy. So they can exist in isolation, but they very often kind of travel in packs or coexist. So why are we thinking about this? Well, they're actually really common. I mean, it's quite hard to estimate from looking at evidence in healthcare settings because we know that they are underreported, and even when they are presented, they're probably undercoded or underdocumented. So for the people that look at these things using kind of large data and epidemiology and observational studies, I think those probably all tend to under ascertain and under record. But we think that in the UK anyway, menstrual problems are about 15 to 20% of all referrals to gynecology services. About nearly 40% of teenagers have heavy menstrual bleeding, and between 70 and 95%, depending on how you measure it and what tools you use, of young people experience painful periods. In adulthood, that's estimated at being slightly lower, but still about 30% of women are living regularly with significantly or severely painful periods. And about 30% of women have severe premenstrual syndrome. My research in looking at GP records for teenagers would say that about 3% have got a coded record of period pain. And if that is how many people we're seeing of the 90 to 95% of people that probably live with it, I think that starts giving us a bit of an idea about the extent of under-ascertainment and under-representation in research that I think we might see a little bit in clinical practice, but I see a lot of people every day with menstrual problems. And I would say that the more you ask about it, the more you hear about it. So that kind of bringing those questions when you see someone with thyroid disorder to say, tell me about your periods, how are they? And you see someone who tells you they're very tired, ask about their pelvic pain, ask about sleep, ask about periods. A lot of people with very heavy periods, for example, are up in the night, changing pads, changing sheets, or lying awake, kind of vigilant, waiting for the feeling, worried that that might happen or trying to avoid it. And all of that cumulatively, particularly together with pain, is exhausting. We see a lot of people with exhaustion. It's not all of it, but it's worth having it in your head as something to ask about. Because I would say that across ways of researching this and across studies and across domains, menstrual symptoms that are causing kind of impacts on well-being have really, really significant adverse impacts on people's emotional, mental, and physical well-being, and on their relationships, on their participation in work, and in kind of everything through life. And probably we don't ask about it as often as we maybe could. So I was just going to show you a little bit about the range of ways in which we know this. This is a lot of qualitative research. And the reason I guess that I thought I would just pull this out is there's a lot of literature that kind of helps us understand the impacts of menstruation on the people who are bleeding and the burden on it. But one of the things they also tell us about is how they internalize it, how they make sense of it, how it becomes normalized within themselves, and also often, frequently in their accounts in medical settings. And I think that impacts on both how likely people are to talk to doctors or healthcare professionals about their periods, and maybe how confident or comfortable healthcare professionals are to ask about it as a symptom, to think about it, to make sense of it. And I'm just going to read you a couple of these quotes. So women should just expect, the doctor told me the problem nowadays is people take the word pill, they don't even know what a real period is. They could at least have made me feel as though they took me and my symptoms seriously. Or this woman talking about someone with heavy bleeding that she needed a lot of medical treatment for, but for years you think it can't be that bad, it will just get better, I really can't bother them with this, I just thought it was normal, I just have to stick with it until I get to the menopause. It never occurred to me to try to seek help. And certainly in the UK where I work, this is increasingly kind of maybe embedded and recognised in policy, and that is because there's a kind of growing critical voice or critical collection of people who menstruate saying it kind of enough already, that their symptoms are overlooked, ignored, dismissed in healthcare settings. So that's now a kind of emerging context in which we work, where there is this experience, and often a shared experience, it's quite often shared on social media, of almost an adverse expectation of healthcare or of healthcare encounters about menstruation. And I guess one of the things that I think about quite often is how we as health professionals and as medical students, as everyone who's encountering these people, what's our kind of collective role in understanding how we can maybe turn that story around so that we can help our clinical spaces be somewhere where people don't feel dismissed or ignored or neglected, where they do think that periods are something that you can bring to the doctor, that you can ask about, that you can talk about, and where we feel comfortable asking about them in the context of whole body domains. If you're starting somebody on treatment for cancer, if you're starting somebody on arthritis treatment, we maybe ask about pregnancy risks, but we maybe don't think about the impacts of those treatments on menstruation. And we could, I think whatever bit of medicine we go into, these are things that we could be thinking about. And I think increasingly we kind of divide up healthcare, I guess, into these different sections. And I guess I may be reflecting on things that, you know, some of these more unifying experiences across half of the population that can be considered in a lot of different settings. So if you're in a psychiatry clinic, or adolescents with learning difficulties, for example, are very, very rarely asked about their periods, or very, very rarely offered support. And yet there is actually a growing body of evidence about quite what a big part of their experience of being a young person and their carers' experiences is about managing that distress, the pain, the bleeding, the behavioural changes. And there are things we can do, but we can't do them if we don't ask. So again, there's another quote here. My endometriosis was overlooked. I was just told it was period pain and to deal with it. It's part of being a woman. I've got no right to go to A&E because my period is normal and I'm exaggerating my pain and it's all in my head. So just before we go on to maybe some more textbook medicine, I just think it's worth recognizing that all of these conversations, part of the reason why they're perhaps complicated for people to come to us, and that I think are probably also relevant as healthcare professionals who are also embodied people and who live in the world, is that there's this really wide kind of background context of what are called menstrual etiquette. So by that we mean the invisible, the hidden social rules about menstruation that this study summarizes here. But you'll see that they're all about privacy and about concealment. And if our patients who are coming to see us, or the people we're talking to in clinic and in the world, have had this kind of quite pervasively drummed into them in their education at schools, often in their upbringing, that menstruating is private, it's something you should keep quiet, you shouldn't really make a big thing about the pain, and certainly you shouldn't really talk about the blood, and the blood is heavily stigmatized and taboo. And you will probably recall that often in kind of adverts for menstrual products, the kind of key messages are all about concealment, which is, after all, I guess, reasonable if what you're trying to do is sell a product that will soak up the bleeding. And that is what people want, but they all kind of add together and contribute to this really widely held social sense that menstruation is quite a difficult thing to talk about, and that you shouldn't talk about the pain, and you should cope with the pain and manage it. It becomes very much a spectrum, and then that becomes very difficult for our patients to make sense of. When is my pain bad enough to come and ask for help? What is bad? How does my pain compare to other people's? How might I find that out? And as doctors, I think we're given kind of guidance about the likelihood of certain conditions based on the severity of pain. I find those very, very hard to navigate. And my work with people experiencing period pain is that they find them incredibly difficult to navigate and to know what severe pain feels like. And there are kind of validated scoring systems, like kind of, I think there's one called the Moose score, and there are menstrual pain scoring systems. But the way in which we complete those scoring systems is influenced by what we understand about how much we're allowed to talk about periods. And this all comes into our consulting rooms and our clinical rooms. So the concealment imperative for pain and bleeding. So I guess this is where that message as a doctor comes in, about thinking a bit about how you might feel about this and where you are with it, but being curious, being asked, creating those neutral clinical spaces. If somebody does come in and wants to talk about it, being prepared to go with them on it, but maybe asking questions when it might be relevant, when it might not, but also maybe then recognizing the kind of work that that person will be doing in terms of being able to talk about it or what it might mean. Think about the other people in the room. Maybe think about leaving doors open and asking people to come back. And I may be overemphasizing that, but I think from my experience and my research, this first bit of starting the conversation is maybe the bit that goes wrong, and that is a really important part of how we can offer care. And finding out about these symptoms is our doorway to understanding the likelihood of conditions that we really want to know about and that we want to be able to help people with. Does anybody have any comments or questions so far? And please tell me if this is unhelpful or totally off-piste. Otherwise, I'll carry on. Okay, so dysmenorrhea is menstrual pain. Dysmenorrhea comes from the Greek, which means painful flow. As I said, it's common, or at least it's commonly known about, commonly experienced. So if you ask people in the population, it affects somewhere between 30 and 90% of people. So a lot of the people that we are seeing in lots of contexts will be experiencing this. What is harder to understand is how we can unpick which of the people with dysmenorrhea might have a contributory or an associated or an underlying kind of pathology, if you like, or a medical condition. And that is obviously the critical part of our assessment. And when you read guidelines about this, they and in the textbooks, they categorize it into what's called primary dysmenorrhea and secondary dysmenorrhea, where primary dysmenorrhea is menstrual pain in the absence of identified, and I say identified carefully, but in the absence of identified, recognized, understood pelvic pathology or a pelvic cause. And in that model, we think that dysmenorrhea is predominantly the kind of impact of prostaglandins on the uterine myometrium and the pain associated with the process of shedding and passing the menstrual fluid. Secondary dysmenorrhea is then usually defined as menstrual pain in association with another pathological cause. And there are a number of those, but they include fibroids, adenomyosis, endometriosis. And usually then what they'll say is that the pain of secondary dysmenorrhea is attributable to the secondary cause. But of course, it's still probably mediated through the same pathway of prostaglandins and endometrial contractility and the passage of blood. I am not certain how helpful that categorization is, although I recognize that it is part of every exam and every hierarchy and every textbook. I guess I would reflect on two things. Firstly, it's quite hard to tell them apart. And most of the evidence that we have about primary dysmenorrhea, almost sort of certainly epidemiologically, almost certainly includes people who've got secondary dysmenorrhea, but where the underlying cause hasn't been identified or found, because we know there's under ascertainment of all of the conditions that cause secondary dysmenorrhea. Perhaps more critically, I think that it almost risks kind of creating the idea that there's a hierarchy of importance, whereby the pain kind of almost matters more or is more significant if we've associated something with it. And I would challenge that. I would say that all of the pain matters exactly the same. Identifying an underlying and associated condition helps you target perhaps evidence-based interventions, although they're often the same whether you found a cause or not. But actually, increasingly what we're starting to see is that all menstrual pain matters. There's kind of new evidence that menstrual pain predicts or increases the likelihood of other chronic pain conditions and other pain throughout adulthood. Adolescent period pain increases the likelihood of any other chronic complex pain. So I think and we know from kind of functional MRI scanning that menstrual pain causes kind of central changes in the nervous system. So the pain itself matters. The pain itself also stops people going to school. It stops them playing sport. It stops them going out. So it has much wider impacts. So I guess my first message is all pain matters. And we need to make sure that that is, I think, the central kind of message when you're seeing somebody. But your next clinical job is then to try and unpick what might be causing it. So the sorts of questions that you might ask are about when they started their periods. And that's not because it's normal to have pain when you first start your periods, but because the kind of relative timing from menarche to the onset of pain might lead you towards thinking about other things. So certainly if you've had really, really severe pain since menarche in a young person, and particularly if they've got any other kind of developmental anomalies, particularly of the urogenital tract, you might be thinking about congenital development anomalies or imperforate hymen. So really severe pain from the minute they start bleeding. As I said, particularly in young people, think about congenital developmental anomalies. Do they have other cyclical symptoms affecting the bladder or the bowel, particularly kind of cyclical bladder and bowel symptoms? Are we then thinking about endometriosis? Have they been pregnant? Have they got other conditions? Are they taking other medications? What have they tried? What have they not? Family history of endometriosis is increasingly recognised as a risk factor for endometriosis, but I would put to you that given how under-ascertained and underdiagnosed endometriosis is, that I do ask about a family history of endometriosis, but I also ask about a family history of severe periods. And I hold the uncertainty within that there is the possibility that some of those family members with really severe menstrual pain may well have had endometriosis. So I regard family history of really difficult periods as an important thing to think about. Guided by the history and consent, you would think about doing an examination. I would say that you should always do an abdominal examination. You might well feel large fibroids or other masses. And in young women, in people who are sexually active, you would do a speculum. Think about pelvic inflammatory disease and sexual infections, which can also be a cause of kind of increasingly painful or progressively painful periods. So you want to think about things like swabs. You might, if they're sexually active, you would never ever want to miss a complication of pregnancy. I realise that talking about menstrual disorder and pregnancy together seems like a bit of a paradox, because but what you're interpreting as menstrual bleeding could be irregular, erratic bleeding, and you would never want to miss an ectopic pregnancy. So in any person who is sexually active who has got painful bleeding, unless you've got very good reason not to, I would always do a pregnancy test. And then I guess also at any age you're thinking about things like ovarian cysts, and certainly in older women, or at any age you might be thinking about cervical cancer and ovarian cancer. And you might be thinking about things like coil-related pain or coil insertion-related pain, or depending on how long they've had it. So you're going to direct your tests and your assessment against all of those things. I would say that the majority come out in the history. And the history of changing periods, or whether they changed or when they became painful, gives you a lot of this information. So I was going to work through a case now with a teenager. I've probably accidentally covered a bit of this as we've been going, but Sam is 15. Their period started 3 years ago, and for the last couple of years, it's getting really kind of much worse. They're not sleeping, and they're missing quite a lot of school. And they've made it to CE, so they're really struggling. This happens worldwide, so I've mapped what I can find about prevalence, and it's remarkably uniform. And the impacts on school activity and other education is also remarkably uniform, as are the impacts, as is the fact that most young people don't come and see healthcare professionals about their periods, but they might well be seeing us about other things. So we can see if we can create spaces to ask. So this is what I've pulled together as a kind of pragmatic approach. As I said, it's absolutely not exhaustive. But for me, this is the list of kind of prompts of things that I think about. And I think we've covered quite a lot of them while I've been talking already. But other genitourinary symptoms, discharge, what have they tried? Have they had over-the-counter non-steroidals? Have they helped? Have they had hormonal contraception? Was that for contraception or for pain? Has it helped? Are they worried? What are they asking for? Do you have a hunch that something doesn't seem quite right? What's the examination like? And then this is the really important thing, and is that are their symptoms not managed with empirical kind of what you try first? If you look at any kind of the international guidelines that I have looked through for period pain, this idea of a trial of treatment is really embedded in them. It's embedded in endometriosis guidelines. I think we'll start seeing it in abdomen guidelines. We see it in PCOS guidance, and we see it in symptom-focused guidance. So this challenge of offering a treatment and then seeing how it goes. And I think that is possibly, well, in fact, I know from my work that is a point where we maybe lose some of the people in the diagnostic journey. And I think that our systems, certainly where I work, are better at the offering of the treatment, but maybe less good at the following it up and really, really hearing about whether it's helped or not. And I guess there's a risk that if particularly young people, anybody is given a treatment for something that they found it difficult to see you for and that is difficult to experience, and they think that the first treatment you gave them either wasn't something they really wanted, but they kind of felt they had to have it, or they tried it and it didn't help, that people often think, well, there's no point going back. They didn't listen. There's nothing for me. This isn't going to help. And I think that starts building into what we see about really long journeys to diagnosis of conditions like endometriosis. So there is something that we can do about really creating a kind of pact when we see people, about being really clear that I really, really want you to come back and tell me, and I want you to tell me if this hasn't helped, and this is how long I want you to try it for. Guidelines vary, but they usually say 6 to 12 weeks, and then come back. If you've got any concerns about any of these, you should do a pelvic ultrasound scan, remembering that they're very helpful for some things. If there's a fibroid, they'll probably see it. If there's an endometrioma, they'll probably see it. If there's an ovarian cyst, they'll probably see it. If there's coil in the wrong place, they'll probably see it. If there's superficial endometriosis, they probably won't see it. So a negative scan doesn't rule everything out, but it does help rule some things in. So we have to use it in that way. And again, I think that's a bit of information that we have to share with people when we're referring them for a scan for dysmenorrhea, because my experience is that people quite often come back and are really disappointed when there was nothing on the scan and think that means that's it, and it doesn't. And so we have to have that as a bit of a shared expectation. So how are you going to treat it when they first come? You want to be thinking about the impact that we've talked about. Do you want to ask about other menstrual symptoms? As I said, they travel in packs. You definitely need to think about anemia and the impacts of the cycle on emotion and the other things they're experiencing with their menstrual cycle. Think about what hormonal therapy might mean to them. Think about how they're managing the bleeding and the things that might help with that. Consider whether they have any other health needs. Do they want contraception? How do they feel about hormones? I think I increasingly come across young people who don't want to take hormones, and that's okay, but it's quite helpful to have a space to talk about it, maybe to explore what they think about hormonal treatments, what their barriers might be, what might make it safe for them, what might make it acceptable, what they've heard, where they've heard it, and what they've learned. And sometimes kind of coming at that, I know you've had a lecture from Neda already, but coming out with a bit of evidence about their place and their role and the way they can help sometimes is enough to change a conversation. And sometimes that can help people. If I am using hormones, I tend to use desogestrel initially, because there isn't any estrogen component in it, but that might cause irregular erratic bleeding, as you know. For some people that's tolerable, for many others it isn't. Always important to tell people about amenorrhea, because sometimes that really frightens people. I think increasingly when we're using the combined hormonal contraceptive pill in the kind of newer regimes where you might take it continually until you get a bleed and then you take a break, or you're tricycling or bicycling packets together to really minimize the number of bleeds, that can be really, really effective for managing dysmenorrhea for people who want and feel able to do that and don't have any contraindications. But they do need to understand and have a really clear expectation about not bleeding and then what to do when they do bleed. So non-hormonal things that do help are, actually, do you know what? There's evidence that giving information and resources helps. Exercise is an evidence-based intervention for dysmenorrhea, but I guess the caveat to that is quite a lot of people know their own bodies and know they really, really don't want to do it. So I tend to say exercise helps if you look at the evidence, but you'll know yourself what does and what doesn't, but certainly don't feel that you shouldn't, because it can be really helpful. Always worth checking use of over-the-counter medication. There's quite a lot of evidence that young people using over-the-counter analgesia for self-managing period pain quite often use either suboptimal or unsafe excessive doses. So taking the opportunity to kind of touch base about that is really helpful. And as I said, plan your follow-up. So that is, and I wouldn't do anything particularly different with adults. So that's a bit of a pragmatic approach to dysmenorrhea. Have a low threshold if your initial treatment isn't working, to make sure you've created a space where they know that that matters, that they can come back, that you want them to come back, and that you refer them on. And a negative ultrasound scan shouldn't mean that you don't refer on. So does anybody have any questions on that? Or I'm going to whip on to heavy bleeding. I've got the chat on if it's easier to put it in the chat. Okay. So heavy bleeding. This probably affects about, as I said, 27 to 36, 40% of women when they're surveyed. I don't think 27 to 36% of my patients come and see me with heavy bleeding, but I do try and hold in mind that lots of them are probably having heavy bleeding. How to define heavy bleeding is something that gets debated a lot, and it's something that gets embedded in clinical definitions. But those clinical definitions can be really, really hard for our patients to kind of make sense of and navigate when they're coming to see us. So a normal menstrual cycle is 21 to 35 days long. The bleedage lasts an average of 5 to 7 days. And apparently a normal average blood loss is 25 to 80 mils. I have never yet met a patient who could measure their blood loss in milliliters. This often gets translated into guideline into the number of teaspoons or tablespoons of blood loss. Also incredibly difficult to make sense of and to compare, and feels quite minimizing to the people I've talked to. So both expressing pain, but really talking about how much you're bleeding is really difficult. So what I find really helpful in the NICE guideline is that which is our kind of English national guideline, and they're all kind of freely available online, is that they don't do that, because in clinical practice, we don't ask someone to measure their blood loss before we decide if they're worthy of treatment or care. Women's self-assessment of blood loss usually massively differs from measured, kind of, and potentially in both directions. And it's really subjective. So I think the most important thing is what is bothersome or difficult or experienced as uncomfortable and heavy for the person. And if we include all the people who experience their bleeding as heavy within that, then I think that's probably a safer and more inclusive way of approaching care. Because as I said, I've never yet anybody who could tell me they lose 80 milliliters or more of blood per cycle. We often use proxy measures, like how often people change pads or how often they flood through. But again, those might be limited by how many pads you've got access to, or by your tolerance, for example, for contact with menstrual products. So I know my have been speaking with people who are autistic. You know, people just might have different tolerance. So they're all quite good proxy measures, but none of them on their own kind of necessarily rule it in or rule it out. So I think it's quite, for me, I take a really pragmatic, if the person comes to me and says, I'm finding my periods really heavy, then they are, and we can start with that. It's and about 5% of people could probably come and see their GP because of heavy periods in the UK. And so you can already see that that is a lot less than the people who probably experience it. So again, what might cause it? Well, this says in about half, no specific cause is identified, although I think there is room to be a little bit reflective about how you get those statistics. But I guess the important point is, a bit like pain, we might not find an associated cause. That doesn't change the pragmatic approach of offering treatment or impact on how we respond to or recognize the importance of the symptom or the clinical presentation. But if you do know the cause, it helps you guide the treatment a little bit. So the common causes are things like fibroids, and that can be endometrial polyps, uterine fibroids. I think it is really worth thinking about malignancy here. So cancer of the ovary, uterus, cervix, or the endometrium. And again, you're going to be thinking about heavy, painful periods. And we think a lot about irregular and unpredictable bleeding, but I have certainly seen cervical cancer present with extremely heavy, painful periods, or what were interpreted and constructed as menstrual periods or menstrual bleeds by the person who brought them to us. Again, heavy bleeding increasingly recognized as a symptom of endometriosis and certainly of adenomyosis. Heavy bleeds are associated with polycystic ovary syndrome, and that's probably because you've got the relative estrogen excess and then irregular periods. So when the periods come, they're often quite long, quite heavy, and can be very painful. Again, pelvic inflammatory disease. But with heavy bleeding, you also need to really, really be thinking really carefully about systemic conditions. I think it depends a little bit who you ask. When I talk to my hematology friends, they tell me that almost all heavy bleeding is caused by coagulopathies, but that is, of course, skewed by the denominator of who's in their clinics. But coagulation disorders are a really important thing to think about in heavy menstrual bleeding. And again, family history. And I ask again about family history of known bleeding problems, but I also ask about family history of easy bruising or problems after dental extraction, because again, there's just a lot of under recognition. Hypothyroidism, and again, this works both ways. If you've got somebody who you've diagnosed with hypothyroidism for another reason, just stopping and saying, hey, sometimes people with thyroid problems have problems with their periods, how are yours? Apparently links with diabetes, and I'm going to say that I'm not sure I knew that or ask about it as often. So that's something very helpful that I'm going to take into account. Liver and renal disease and hyperprolactinemia, again, I think because you get maybe erratic periods and then very heavy ones. And it sounds really obvious, but I can tell you that I regularly in practice have people come and see me and say, I don't know what to do about this patient's really heavy bleeding. And you say, well, it might be because they're on a Pixaban. So just stepping back and thinking, is it because they're on a blood? Now, the blood thinners are really, really obvious, but what you might have is somebody who's having lots and lots of naproxen or ibuprofen, which of course are treatment for painful periods, and it's making them heavier. So there may not be like an intervention because of that, but recognizing it as an important part of the story can help. And also maybe then you'd think about whether you might add something to it or try changing medications. SSRIs, because of their impacts on platelets. The contraceptive pill, and I guess this is particularly desogestrel, and the Mirena coil here as well. And of course, copper coils, so non-hormonal coils, characteristically cause heavier, longer periods. And there are some supplements that are associated with heavy bleeding. And I guess just worth a word thinking that often we also see heavy bleeding at either end of reproductive life, so they're often much heavier in the around menarche in adolescents, have really high rates, kind of 37%, as I said, but also in the years leading up to and around the menopause, people can have very heavy bleeding. And again, how you approach investigating and managing that might need to take that into account. I guess the relative differential likelihood of things like malignancies increases with age as well. So a case, I've deliberately picked a perimenopause one here. So Sarah's periods have always been heavy, but they're getting much worse. And actually, it's becoming now quite difficult for her to leave the house for the first 2 days of her period, and she floods the bed at night. And she has made it to see you. So what sort of things do we need to include in the history? Again, they're all really, really obvious. So is the bleeding sudden or gradual? Has it always been like this? Are her periods regular? Is the irregular period actually the driver of the heaviness? How often do they come? How long do they last? I've had people come and see me and say that they've got heavy bleeds, but when you ask about it, they're actually bleeding daily for weeks on end, and that's a different presentation or a different way in which we might interpret it, and a different set of tests and interventions. So when you say period, what do you mean? How long does it last? Do you have gaps in between when you're not bleeding? Seem like really obvious questions, but I still get caught out by that question on a kind of really regular basis. Do you bleed after sex? Did it come on after birth? Have you got bleeding in between your periods? Have you got associated pelvic pain or pressure symptoms that might suggest something like a uterine cavity abnormality or adenomyosis or fibroids? You're going to ask about an obstetric history and the changes in menstrual periods throughout their life, but also ask about, recent medical procedures, comorbidities, other things that they know that are relevant. Have they had a history of bleeding, bruising, coagulation problems, medications we've talked about? Have they had a smear? And I would also really actively ask about symptoms of anemia. My experience is people don't volunteer these when they've come with heavy periods, but the majority or many of the people that you see will have either a hemoglobin or a ferritin deficiency and will be symptomatic from that. And as I said, the converse is true as well. When you pick up incidental anemia, of course, I think we probably remember to ask about menstruation. Menstruation globally is the most common cause of iron deficiency anemia, but people can be really profoundly symptomatic. And in my experience, they often don't volunteer that unless you ask. I would think about doing an ultrasound scan. So actually where I work, they're quite hard to get for just heavy bleeding. But if you think somebody might have fibroids, particularly once you've examined them, then that is the right thing to do, because the guidance certainly that we use in the UK, if there are fibroids, is kind of predicated on the size of the fibroid, and I'll tell you a little bit more about that in a minute. And then you're going to think about clotting, full blood count, think about swabs for infection. So what are the first line treatments? Well, I would say the first line treatment that we offer is thinking, am I worried about malignancy? Do I need to do an urgent referral? So things that would make me do a very urgent referral or be really worried are, again, not surprising things, but like a pelvic mass, weight loss, unexplained bleeding, a really marked change, post or very perimenopausal women, kind of older 50s, bleeding more than a few months, 6 to 12 months after menstruation has stopped, an abnormal examination of the cervix, a history of abnormal smears. And remember to go above the gynecological examination. If we're thinking about ovarian malignancy, we need to be thinking about ascites, other abdominal masses, ask about bladder and bowel or kind of obstructive, suppressive symptoms. And if someone's got really big fibroids, you might well feel it, but they might also have a history of fibroids or a history of fibroid treatment. So you're going to be referring urgently and doing, I think for me in parallel, I would do an urgent ulcer, but I would not delay referring to a gynecological specialist for any of those things. I would also refer pretty urgently if somebody's got really significant anemia. You'd certainly be admitting or referring if they need transfusion. And I have certainly, in fact, in my current study with young people, have been talking with teenagers who've needed to have blood transfusions in their very early teens because of menorrhagia. But anemia that's not responding or other causes, or you haven't found anything else. So that's when you would refer. When you're waiting for treatment, and if you think there might be a malignancy, I wouldn't give hormones, but if you need to give something, you can give tranexamic acid or a non-steroidal if it's not contraindicated. If you haven't got any of those reasons to refer and they have got no identified pathology, or they've got fibroids less than 3 centimeters in diameter, not distorting the uterine cavity, or suspected adenomyosis, our guidance suggests offering a hormonal coil, so a Mirena or an LNG-IUS coil as the first line. Obviously counsel about changes in bleeding and what to expect. If they don't want a coil or it's unsuitable, and I guess the other group to think about here are people who want to get pregnant, and if what they want is to get pregnant, and so hormones are contraindicated, but they're having trouble with pregnancy, in this case for either pain or bleeding, I think that is another reason to try and refer on as quickly as you can. Non-hormonal options are tranexamic acid, which will slow the bleeding. You can use non-steroidals. Mefenamic acid is said to reduce bleeding because of impacts on platelets. I don't think the evidence behind that is immensely robust, but they are commonly used. They do have a bit of risk of renal problems, and so I actually quite often use naproxen, but that is an off-license use. And the hormonal options are continual combined hormonal contraception, cyclical progestogens, and norethisterone can be used. Remember that if you're using high-dose norethisterone, so 5 milligrams TDS, enough of it is converted to ethinyl estradiol systemically that the contraindications for combined hormonal contraception in our guidance are applicable to that. So just think about, my rule of thumb is if I wouldn't give the combined hormonal contraception to someone because of a medical contraindication, then I won't give them high-dose norethisterone. Surgical treatments depend on the cause, but things that you might come across that can be really effective are endometrial ablation, and that can be microwave laser. There's lots of ways of doing that. Uterine artery embolization, which can be really effective for localized fibroids and things, can be quite painful. Myomectomy, and that's where you're trying to preserve fertility, or ultimately hysterectomy. Sorry, that should have a T. So last symptom that we see quite often, and again, this is in the context of sometimes of concerns about fertility and trying to get pregnant, might also sometimes just be about difficulty in navigating this. I guess we see it more, I certainly see it more and more with an increasing use of apps that are telling people, menstrual tracker apps that are telling people they ought to come and that it's a problem and that it's worrying. But this is our textbook definition of irregular periods. So they're coming more often than 21 days, and that's from day 1 of bleeding to the next day 1 of bleeding, or more than 35 days apart. I think that there is irregular in that sense, but there is also the erratic enough. So some people have predictable periods, but at an interval that isn't 21 to 28 days or 21 to 35 days. But some people have highly irregular and unpredictable periods, and I think that's often quite tricky to manage because of the unpredictable nature of it. I think increasingly one of the commonest things that I see is people who are taking hormonal contraception and who are presenting the hormonal withdrawal bleeding that they experience as part of taking hormonal contraception as a menstrual cycle. And so that might present it as irregular periods. So irregular periods, and I've certainly have the experience of getting quite a long way down a consultation about irregular periods before realizing that somebody's got, for example, a Nexplanon or an implant in. Weight changes, so weight gain and weight loss, stress, exercise, but also the systemic things. And I think the commonest ones that we think about are, again, hyperprolactinemia, thyroid disease, polycystic ovaries, and we're thinking about premature ovarian failure, and you would target your history and examination guided by them. I'm going to say a couple of words more about polycystic ovaries before I finish. So just a few words then, doing this in the more conventional way, about conditions. If you've covered these already and this isn't helpful, then my apologies, and please tell me. But endometriosis, it's quite hard to know what the true prevalence is, but the estimated prevalence is 6 to 10% of women, which equates to about 190 million women worldwide. It's increasingly kind of recognized as a chronic inflammatory, so a systemic rather than a gynecological disorder. In fact, it's just recently been robustly linked to autoimmune conditions, but it's a chronic inflammatory disorder. And as you know, there's tissue similar to the endometrial lining, which is found outside the uterus. The majority of that is pelvic, so pouch of Douglas on the ovaries and fallopian tubes, but it can be on the bowels, it can be on the bladder, it can be under the liver. Very, very rarely it's in much wider spread places. So the most well-documented ones are lung, where you get kind of catechenical hemoptysis, and brain. That's incredibly rare. It is incredibly important, and hope that anybody with cyclical hemoptysis would be referred and investigated. So I'm going to focus on the kind of pelvic abdominal cavity endometriosis. It's a really, really heterogeneous condition. And I guess the complexity in understanding the heterogeneity is in its under ascertainment, because it's really difficult to diagnose, because to diagnose it, textbook, you need a laparoscopy. So somebody needs to have turned up in your clinic, then you need to have thought of it, then they need to be referred. They need to pretty much always have not responded to whatever you tried to treat them with. They then have a laparoscopy. It might show up on an ultrasound, as I said, particularly in endometrioma. Increasingly, sometimes you can see suggestions of scarring, adhesion, or fixity of the pelvic organs. And there is increasing interest in highly detailed ultrasound. And I think this is going to change in your working lives. And I really hope so, because I think the more we understand about the breadth and range of people who have endometriosis, the better, precise, specific guidance we'll be able to give you on that really difficult first question I started with, which is, how do I tell the difference between primary and secondary dysmenorrhea? As things stand, the gold standard diagnostic is a laparoscopy where somebody sees the endometrial-like tissue. It responds hormonally, so it can bleed with menstruation, so you often get really marked pain that can be experienced in period pain and pelvic pain, but can also be experienced across the bladder. So cyclical bladder pain, I think, is a really important thing to ask about, and cyclical changes in bowel, or even sometimes cyclical rectal bleeding. But I think we spot that, but it's actually often cyclical changes in bowel symptoms. So dysphagia, which is these really painful bowel symptoms, and dyspareunia, often because if you've got scarring, you've got relatively fixed pelvic organs. But it can be asymptomatic. And one of the difficulties is that the people that we know it in are the people who are symptomatic. So a lot of our evidence about who's got endometriosis are kind of retrospective studies in people who are in tertiary care or really specialist pelvic pain clinics. And in them, like 30 to 60% probably have endometriosis. Likewise in subfertility clinics. But if you start it the other way around with a person with endometriosis, I don't believe that we have yet the knowledge or the evidence to predict what it will mean for their fertility or for their likelihood of long-term pain. So I think that's quite a difficult bit of consultation, but it's really important maybe to be transparent about that uncertainty. That we don't know. And for some people, it is found incidentally, at appendectomy. And it's quite hard to know how to treat them. It's got implications. So in terms of treatment, for deep endometrioma, there's evidence for treatment. There's little, or it's equivocal at best, evidence for treatment of superficial endometriosis. If you have treated surgically for a deep infiltrating endometriosis, then post-operative hormonal therapy reduces the risk of recurrence. But there is always quite a significant chance of recurrence, which brings me back to what I was saying, that this is a chronic enduring disorder and people need longitudinal care and they need the opportunity to keep coming back, because when they've had treatment, there is a really good chance that it will recur, and that's really important to have as a shared journey with them. Medical treatment includes pain, which can include a pain relief, and that's really important. Sometimes neuropathic pain medications can help. So, menstrual suppression with GnRH analogues, often with HRT add-back therapy. There's a new oral version in the UK, which has been kind of hailed as the first oral medication that does both those jobs for endometriosis. That's quite an exciting thing to see. Hormonal suppression using combined hormone and compression, or as I said, increasingly I use the progestogen-only pill because it doesn't have estrogen in it. There are lots of non-pharmacological measures that have got really good evidence. So pelvic floor physiotherapy can really help with endometriosis-associated pain, as can CBT. And if people are interested, I've got some free kind of sheets that you can give patients that they can do that for themselves. That can be quite helpful. And don't forget to ask about extra pelvic symptoms and that those might need symptomatic support and treatment. This is a pragmatic flowchart about how you might navigate that kind of slightly complicated journey. This comes from a BMJ state-of-the-art review about endometriosis. I won't go through it in details, but I think I put it in because I think it speaks to the real world of clinical practice of seeing someone with symptoms and how you might work through it, but also speaks to the complexity. But I think the idea is that if you've got signs of endometriosis, you say they might have it. If they've got infimotility, you refer. If it's really complicated, you don't. If they've got pain, you think about where a diagnostic laparoscopy sits in, but you'll see that that comes in quite far down their journey through care. Adenomyosis is an interesting condition where you've got endometrial-like tissue and stroma, which is back in the myometrium. It overlaps, there is an obvious overlap, isn't it? It's endometrium in the wrong place with endometriosis, and there is very significant overlap between the two conditions. At the moment, they are considered separate conditions, and they can coexist or they can exist separately, but the presence of one really does increase your clinical suspicion about the potential for the presence of the other. They can cause heavy menstrual bleeding and intermenstrual bleeding and pelvic pain. Yes, it is. That's a very good question. So the dysmenorrhea caused by endometriosis is usually relieved by non-steroidal anti-inflammatories, not usually often. And that brings me back to the point I made at the beginning, which is that actually the dysmenorrhea pain is mediated to an extent through progestogens as well, because you're still bleeding. So yes, the treatment for the condition and for the symptom do overlap, which does raise a complex clinical question about their place in referral guidelines, because we refer the people who haven't responded, but they might be responding and still have the condition, which is why I think keeping the door open and just holding that uncertainty is really important. So thank you. That's a really good question. Adenomyosis used to only be diagnosed at hysterectomy. So it was a kind of thought to be a condition that only much older women had. Multiparous women, it was thought that it was the act of childbirth that forced the endometrial cells back into the myometrium, but it's increasingly and with increasingly detailed image diagnosed in much younger people and teenagers and people who've never been pregnant. So I think this is also going to be a massive emerging area in your clinical lives about how much increasingly it is identified and how much it can contribute to people's symptoms. I think the literature from that hysterectomy data said it was often asymptomatic, but that was often from things like case studies of people having hysterectomies as part of things like tubal ligation or sterilization, or in association with those symptoms. And I don't know that they asked them about all of the right symptoms. So I don't think we know how often it's symptomatic, but I think very often it is. And also with the increased reporting on ultrasound, we're increasingly going to see it. There aren't many trials of medications or interventions that have been specifically done in adenomyosis, but non-steroidals and medications that reduce menstrual flow and hormonal contraception, tranexamic acid, often help if they're not contraindicated. So yes, again, a huge overlap about therapeutic options. The hormonal immunocoil is also a first-line recommendation for heavy pain and bleeding adenomyosis. If it's acceptable and tolerable, there is a little bit of evidence that expulsion rates are a bit higher in people with adenomyosis or fibroids. And so I tend to counsel people about that. Again, tell people to come back, ask about symptoms that might also suggest endometriosis, ask about fertility, ask about irregular bleeding, ask about referring on if so. And very finally, sorry, I thought I'd very, very quick whiz through polycystic ovary syndrome, which is a really common cause of irregular periods and contributes for many then to heavy painful periods. So again, about asking across it. It's really heterogeneous, and this can present in the endocrine clinic, in your reproductive clinic, increasingly recognised with kind of cardiometabolic risk factors and overlap with things like MASL. You might see it in somebody who's presenting with acne, and people do experience, again, significant adverse impacts on their quality of life. So the revised Rotterdam criteria regard the 2 out of clinical or biochemical evidence of hyperandrogenism or ovulatory dysfunction. So that is a clinical diagnosis. Symptoms of hyperandrogenism with ovulatory dysfunction evidenced by irregular periods. You can start thinking about this really and talking about it. Or polycystic ovaries on ultrasound. Elevated AMH levels are international guidelines. I'm not allowed to use those. It is worth saying that if you've got irregular menstrual cycles and hyperandrogenism are present, then ultrasound and AMH are not required for diagnosis. So these are international consensus guidelines that specifically talk about this as a clinical diagnosis. And it is worth just saying that in teenagers, ultrasound is not advised. It's really non-specific. And our guidance locally, and certainly in our NICE guidance, is not to do an ultrasound within 8 years of menarche, because ovaries often appear polycystic and you can falsely label people. And that is quite significant. It's worth remembering about the hyperinsulinemia, about the insulin resistance and the metabolic features. And we should be asking about and actively screening for those and optimizing that. thinking about screening for type 2 diabetes, cardiovascular risk factors, checking blood pressure. It is really difficult, and it's a really, really heterogeneous condition. Weight loss does help, but is hard to do. And there is an abundance of evidence that guidance about weight loss and polycystic ovary syndrome is difficult to deliver, difficult to hear, and difficult to experience. I don't think we've yet got very good evidence about how best to help people with it, but there are people working on it, and I really, really hope that's going to improve. Certainly women with PCOS talk about it being harder to lose weight, and we need to recognise that, but also to be evidence-based and tell them that it is quite likely to help them. Metformin is recommended for metabolic features and can be helpful. Cycle regularity with oral contraceptive pills if they are not contraindicated, and you do need to be thinking about those cardiovascular risk factors, blood pressure and BMI when you are making that assessment. Again, desogestrel can help, and you're likely or cyclical progestogens, so that you're shedding the uterine lining, because there is a small but definite increased risk of endometrial hyperplasia and endometrial malignancy. And I'm a couple of minutes over, but so I'll stop there.